Good afternoon, and welcome to today's CME activity. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, we'll ask at the end of the activity, and if you're viewing online, please enter your question into the Q&A chat, and we will ask that question for you. You will also receive a SurveyMonkey link after today's activity. We appreciate your feedback, so make sure you answer that evaluation. It is my pleasure to introduce today's guest speaker, Mark Komrad. He is a psychiatrist and medical ethicist on the teaching faculty of Johns Hopkins, University of Maryland, and Tulane. For over 20 years, he chaired the ethics committee for Sheppard Pratt, the largest nonprofit psychiatric healthcare system in the U.S., located in Maryland. He was a member of the American Psychiatric Association Assembly for 6 years and served 6 years on the APA Ethics Committee. In these two capacities, he helped craft the new APA position statement opposing euthanasia of the non-terminally ill, particularly psychiatric patients. He has published widely on this topic and lectured throughout the U.S., Canada, UK, Europe, Scandinavia, and South America to address serious ethical concerns about physician-assisted suicide and medical euthanasia, especially allowing psychiatric patients to have these procedures that would provide rather than prevent their suicides. Dr. Komrad spends most of his time treating psychiatric conditions. He has a special interest in helping families convince a troubled loved one to get a psychiatric consultation using ideas from his book, You Need Help, a Step-by-Step Plan to Convince a Loved One to Get Counseling. He lectures and gives workshops on these ideas to mental health advocacy and support organizations throughout the country. For this work, he was given U.S. National Alliance on Mental Illness Exemplary Psychiatrist Award and its Mental Health Profession of the Year Award. He was also host of the national radio call-in talk show, Komrad on Call, which broadcast to 43 million listeners throughout the U.S., was a regular guest psychiatrist on medical talk show that aired on NPR, and he continues to appear regularly on TV, radio, and podcasts. He also has consulted to Hollywood to help develop more ethical portrayals of psychiatrists in the movies. Join me in welcoming Dr. Komrad.
Thank you so much. I absolutely want to acknowledge that I have a point of view on this very controversial topic. And I hope today to give you some of the background information and data in the living laboratories where physician-assisted suicide and medical euthanasia is being practiced, with a particular focus where I can on psychiatric patients, and to make the argument as to why I've concluded as a medical ethicist of 35 years that this is neither good medical ethics nor public policy. As a matter of fact, if we we think about the eclipse. I was thinking about this when we saw the eclipse the other day. Frankly, I'm very concerned that medical ethics as we've known it for several thousand years, which many people these days are calling the Hippocratic tradition, is beginning to be eclipsed by some of the practices and embracing some of the ideas behind assisted suicide and euthanasia, so that it's starting to obscure medical ethics as we've known it. And I want to make an argument today as to why that may not be good and may actually be neither good medical ethics nor good public policy. I've been a medical ethicist for these 35 years and generally doing, scholarly things and giving workshops and talks, but it's as if this topic, as if I've been preparing over that time for this one topic, because it has so seized me with concern that I will admit that gradually I'm transforming on this particular topic from an ethicist into an activist as I go around the world speaking to legislatures, policymakers, and so forth, in professional societies to try to make my arguments. So Melville wrote in Moby Dick, woe to him who seeks to please rather than to appall. And as I think I've already communicated, I think this is something that I have found appalling, and I'm going to try to create that sensation in you as to why I feel that way. So I'm a medical ethicist and a practicing psychiatrist, so that's the intersection of medicine and philosophy. And the great philosopher Albert Camus said there's but one truly serious philosophical problem, and that is suicide. And that is what we're talking about today. Our topic today is actually a species of suicide, and I'll try to make that point. Now, what's fascinating is that it's this very month, just last week, that this article appeared worldwide, and many of you may have seen this story, if not this particular article. But suddenly, the euthanasia, voluntary euthanasia of psychiatric patients on request has now come to acute attention in the world. This particular woman in Holland has been suffering from depression, borderline personality disorder, we're going to get back to that point, and autism, and has decided that as a result of this, she is tired of living, and she has requested and been granted, hasn't happened yet, her euthanasia ticket. And this particular healthcare ethicist in the Netherlands said, I'm beginning to see the phenomenon, especially in people with psychiatric diseases and especially young people with psychiatric disorders, where the healthcare profession seems to give up on them more easily than before, now that we have a culture that has an entire generation who has grown up, as I will explain to you, for nearly 25 years now, with this as an option, as a treatment option, by sometimes exhausted and overwhelmed physicians and psychiatrists. I myself, as a medical ethicist, had actually not been aware that psychiatric patients were part of this picture until 2015. It had kind of been hiding in plain sight because it was happening primarily in the Benelux countries, Netherlands, Belgium, and Luxembourg. And I saw this article in the Washington Post. If you were a psychiatrist and a chronically depressed patient told you he wanted to die, what would you do? In Belgium, you might prescribe this vulnerable, desperate person a fatal dose of sodium thiopental. I was somewhat rattled by reading this, began to look into it, and realized that I had missed the memo, that it had been really hiding in plain sight for well over a decade at that point, decade and a half. So it's really been smoldering in the world of medical ethics and really only begin to come into the forefront in the last several years. And I have been part of the effort to try to bring the discussion about this into the forefront. In fact, if you go back, one of the first papers that was published on this from the Netherlands was way back in 1998. I really had to backpedal and go back to find really the origin of all this. All right, let's clarify some terminology. As Humpty Dumpty said, a word means what I want it to mean, nothing more and nothing less. And as with many controversial topics, how you phrase it, what language you use, obviously conveys your point of view. So there are many terms that have been utilized in this space: physician-assisted suicide, voluntary euthanasia, compassionate assistance to die, physician-assisted dying, medical aid in dying, which is the preferred term in Canada, MAID. In Australia, it's called Go Gently Australia. Kind of sounds like a laxative. Death with dignity. Some of you may be old enough to remember here in the US several decades ago, Dr. Kevorkian, he wanted to introduce the term medicide. That never really caught on. Then there's this curious organization called the World Federation of Right to Die Societies that's lately pushing for a new term called dignicide. As far as I'm concerned, this is so much verbicide. So let's just dig into the terminology, because it's important. George Orwell wrote, if thought can corrupt language, then language can corrupt thought. It works both ways, so we need to be careful. So the terminology that really is the terms of art in this field, an increasing level of moral complexity. First of all, The least controversial level is palliative care. This is where we as clinicians get out of the way of death and provide comfort care, state-of-the-art comfort care, which unfortunately is not as widely available, particularly in this country, as we would like, both in terms of training and facilities. But we step out of the way of death. The second level is physician-assisted suicide. What does this mean? This means the doctor writes a prescription for a bunch of lethal medications, mostly barbiturates, where some people call this the box of barbs, that the patient picks up at the pharmacy, takes home, sits on as long as they want, puts it in the closet. Hopefully it's not discovered by their suicidal granddaughter, and takes it at the time and place of their own choosing, with or without witnesses, with or without any kind of attempt to verify there's not coercion being done. And then the most complex, morally complex level is euthanasia. And this term means that the physician starts an intravenous line and administers, pushes a dose of lethal medication. This is lethal injection, really not distinguishable from the death penalty in many prisons, except now it's in the House of Medicine, administered by physicians. So the CDC defines suicide as death caused by self-directed behavior with an intent to die. So by ordinary definition, the definition that we have trained with, that we use, that we deploy every day in our practice, these practices absolutely fit the definition of suicide. Interestingly, though, the American Association of Suicidology in 2017 decided that legal physician-assisted deaths should not be considered cases of suicide because these people don't want to die, they just want to end their suffering, which frankly is no different than my suicidal patients in psychiatry. They just want to end their suffering. But they decided that they would push for parsing of these two ideas and withdraw these procedures from the domain of suicide. We'll get back to what happened with that organization. Camus again, to misname things adds to the world's misery. John Mayer, editor-in-chief of the Journal of Ethics and Mental Health, full disclosure, I'm on the editorial board of this journal. He said, using the term medical assistance in dying, he's Canadian, is an attempt to separate suicide from its value-laden meaning and thousands of years of moral reflection. Because this creates two different kinds of suicide, bad suicide and good suicide. So there's the suicide we should prevent that we're all familiar with as psychiatrists, and the suicide that we should provide. The former we refer to as dealing with psychopathology and treating it as psychopathology, and the latter they're starting to designate as a medical treatment. So it's very confusing. We'll get back to the implications for public health and suicide prevention towards the end. Well, turns out that the American Association of Suicide, their position was being driven primarily by their largest donor. And many of the leadership, the scholars, the clinicians, the board was very uncomfortable with that position, but maintained it for the purpose of maintaining this funding source until finally they decided that's really no way to run the organization. And so they, in March 2023, last year, they decided they're going to step away from the attempt to distinguish these two. They have called the position now retired. So they too understand this confusion that one can set up between two different kinds of suicide and trying to rename one as not suicide. All right, now let's dive in to the topic of these procedures now that we know our terminology for psychiatric patients. And for that, we need to go across the Atlantic to Benelux, Belgium, Netherlands, and Luxembourg, but primarily talking about Netherlands and Belgium. So between 2001 and 2009, these countries decided they're getting out of the conversation that we're in the US, which I'll get to, about the difference between terminal and non-terminal conditions. to say people with terminal illness versus people without terminal illness. They decided that was not the right way of looking at criteria about who would be eligible. They decided instead to replace those with the idea of people whose conditions are unbearable, which the patient gets to decide, and untreatable, which interestingly, not just the clinician gets to decide, there's nothing more we can do for this, but as is consistent with the current and long-standing status quo, state-of-the-art of medical ethics, people can refuse treatments. So the patient also gets to weigh in about whether they're treatable or not. For example, it is considered, established medical ethics if you have end-stage renal disease and you can refuse transplantation or dialysis, in which case you are now terminally ill and you have decided for yourself that your condition is no longer treatable. So unbearable, untreatable, those are the criteria in these countries. And consistent with what we have been teaching in psychiatry, parity, that there really shouldn't be a distinction between those with mental disorders and physical disorders, that suffering is suffering is suffering. They efface the difference between mental and physical suffering. So when you have this formula, untreatable, unbearable, mental suffering could be just as well criteria as physical suffering, you put those together and you open the door to people with psychiatric disorders. And that's exactly what happened. Also, they made legal both physician-assisted suicide, the pills, and euthanasia, the lethal injection by doctor. And in every jurisdiction where both have been made legal, patients far prefer to outsource their death to doctors. And it becomes, as in all these countries, 99.9% of the cases are euthanasia. Nobody wants to take a box of barbs. They want to just have their injection. All right, so let's look at some of the data in these living laboratories that have been going on. So for the last decade, you can see the uptake here in the Netherlands. Now we're up to over 8,000 deaths last year, 2023. There's been a 500% increase since these procedures became legally acceptable, almost 9,000. And think about this. Between 5 and 6, 5.4% of every single human being who dies in the Netherlands last year was at the sharp end of a doctor's needle. So 5 or 6 out of 100 died by euthanasia. All deaths. So it's one of the leading causes of death in Netherlands, death by doctor. By the way, there's some data here in the New England Journal that these may be underreported, that as many as 23% of euthanasias are not being reported as such. Now, what about psychiatric patients? So here's the data. I've deliberately excluded dementia from this because there's a lot of people with dementia who get these procedures, but that's almost an entirely separate talk. So these are ordinary psychiatric diseases. You can see how they've been rising over time. So out of a total of 9,068 euthanasias in 2023, there were 138 cases. So on the average in the Netherlands, there are 2 psychiatric euthanasias every 5 days. Now there are 2 paths in the Netherlands. One path, which is going through your personal physician, and 85% of this group of 5.4% of Dutch people are actually being euthanized by their own personal physician. However, there are many doctors that are uncomfortable with that or opposed to that, don't want to participate. So the Netherlands has made an alternate path available called the Euthanasia Expertise Centers. These are about 60 traveling teams that go around the country. They're typically new to the patient. They may or may not be reviewing medical records. There's no requirement that they do. The typical evaluation is an hour to an hour and a half, and they are zealots. They believe they're on a mission to promote and provide, and as a result, since most physicians are particularly uncomfortable providing this for psychiatric disorders, that most of the psychiatric cases have been done in this specialty clinic. And until last year, 2023, when it dropped. So what's happening is, as this becomes more and more common, as it's more suffused and normalized, Robert Lifton might call it a malignant normality, but as it's normalized, people are getting more comfortable doing it for psychiatric patients. So now this specialty clinic is only doing about 50% of them. In fact, from 2022 to 23, there was a 50% increase in requests from psychiatric patients, of whom 80% were granted. When this first started back in 2002, only 10 to 15% of requests from psych patients were granted. Now, the majority of requests from psych patients are granted, as the medical culture has changed and the fulcrum that balances acceptable killing from unacceptable killing has moved over the course of a generation. Now, here's some data from people who have been euthanized by shouldn't say my own doctor, but who were euthanized not with the specialty center. So 66 psychiatric patients, and you can see the diagnoses, common diagnoses that you might expect: mood disorder, anxiety, PTSD. What's interesting is 8% had psychosis. Now remember, you have to be considered to have capacity to engage in this, and somehow 8% of people who had psychotic disorders were considered to have capacity for this, substance abuse, eating disorders. But the big news here is that 52% had personality disorders. Now, obviously, there's comorbidity here. And as Scott Kim, who studies this at NIMH, has revealed, that these people with personality disorders, that 28%, almost 1/3, had no history of any psychotherapy. Now, this audience understands that when it comes to personality disorders, really psychotherapy is a mainstay. It may indeed be the sine qua non of treatment of personality disorders, but 1 out of 3 were euthanized, even though they had no history of psychotherapy. And 56% refused one or more recommended treatments. Not a surprise. Psychiatric patients all the time are refusing one or more treatments, and we know that that's allowable, because patients are allowed to refuse treatments, as is the ethical status quo, as I explained earlier. 41% of these were euthanized, psychiatric patients were euthanized by a psychiatrist who was providing their suicide rather than preventing their suicide. And since it's back in 2011 to 2014, 80% of these cases were done in the specialty center by psychiatrists who work in the specialty center euthanizing patients. There's a preponderance of women over men. We can talk about why that might be. That's a very interesting and consistent finding. So as of 2022, this paper showed that, again, having lived with this since 2001, an entire generation of 21 years, now 50% of psychiatrists in Holland regularly receive requests for euthanasia from their patients. It's like part of the evaluation, part of the treatment plan discussion, part of the options that are considered, and 50% are regularly asked by their patients. Now, I want to just point out a couple of extra things before we leave the Netherlands. One, the leading party, the D66 political party, which is headed by this woman, Pia Dijkstra, has long been pushing for and is currently still on the path for demedicalizing this, which frankly makes me slightly more comfortable, as I'm trying to make a case that this doesn't belong in the House of Medicine. But what she's saying is that rather than having the criteria of a medical condition, since we've lived with this now for 20 years, let's open this up to anybody who simply says they're tired of living. that they've had a completed life. And let's open our euthanasia centers to people who are not necessarily ill. This is what happens evolutionarily with the ethos of a country that is living with this. And I'll show you something related in Belgium. By the way, don't think that's unique to Holland. Here in the US, there's a whole organization that is pushing for the same concept, the Completed Life Initiative. Now, I want to say something about organ donation. So basically, psychiatric conditions, patients with psych disorders represent 1% of all euthanasias in Netherlands. However, if you talk about organ donation, those people who are being euthanized often want to contribute their organs as to follow their euthanasia. So even though they're 1% of all euthanasias, psychiatric patients are 29%, almost 30% of all organ donations after euthanasia. You can see some of the diagnoses there. So I want to point out who is the most, who has the best organs for donation. Generally psychiatric patients. Unless they're substance abusing, they typically have pretty healthy organs. And this basically sets up a virtue opportunity for people who have decided, like our young woman that we started with, who have decided that their life isn't worth living, that they're suffering, that their life no longer has meaning, and are very attracted to the virtue opportunity of making something of their life in death by donating their organs. So there's a tremendous disproportionate and I think coercive field that is attracting the psych patients. And remember, 50% increase just in the last year of applications from psychiatric patients for these procedures. Here's one psychiatric patient who said, "I thought the knowledge of having full autonomy by way of maid was comforting, but when the possibility of organ donation was added to it, the sense of elation is the only appropriate word for me." You know, Horace wrote about a ethos in ancient Rome that was called Roman suicide. He wrote, "It is marvelous to die for one's country." And in ancient Rome, relieving your family of the burden of you, if you were impoverished, if you were sick, if you were ill, was considered virtuous. So that's the eponymous Roman suicide, which I think is what we're seeing here. Now, let's move down to Belgium. So Belgium has a couple of unique features. One is they have euthanasia tourism, as it's called. You can come from any other country and have euthanasia there. Since 2014, they've opened it up to any age. Children of any age can have it. And they're also a country that has advanced directives so that you can plan, if you develop dementia, to have euthanasia. And that can get complicated, as maybe we can discuss. So here's the rollout in Belgium. Since for the last decade, there's been 1,000% increase in uptake there. Their prevalence slightly lower than the Netherlands. 4.5% of all people who die in Belgium last year died by lethal injection given by a physician. Last year, 20% of these people did not have a terminal illness. You don't have to have a terminal illness. Remember, that's not one of the criteria. It's just got to be unbearable and untreatable. There were 110 people from outside the country, and 19 of these were done by advanced directives. And again, another article in the New England Journal suggesting that there's a serious problem with underreporting. So these statistics may be lower than you would than are actual. So here's the situation with psychiatric patients, and it grew and grew until 2019. 2019, they changed, I said change in law, that's not entirely accurate. They changed the guidelines, it's guidelines, not law, for psychiatric patients only, not for any other condition. For psychiatric patients as of 2019, you had to have exhausted all evidence-based treatments. So, you know, the 30% of people with personality disorders who didn't have psychotherapy as of 2019, that was no longer possible. So that drove down the numbers for a couple of years, and now they're starting to rise up again. Again, predominantly women, female. 75%, now again, and there are people now in Belgium, Netherlands, who have, when they started medical school, in fact, when they were kids, that euthanasia was in the palette of options for medically ill patients, for psychiatric patients. So by now, 75% of psychiatrists in Belgium feel comfortable with this being a treatment option for eligible patients. And 8% of psychiatrists say they're willing to perform it on their own patients. The same patient who's suicide, the same exhausted psychiatrist who's caught up in the dance of countertransference and projective identification is now willing to say, okay, rather than preventing your suicide, not only am I willing to support it, I'm willing to personally kill you. That's a generation. So here are 57 patients in Belgium euthanized in 2019. You can see the different diagnoses. Once again, personality disorders, 45%, almost half of the Belgian people euthanized were euthanized because of personality disorders. And which personality disorders? Well, it will be no surprise to this audience that the majority have borderline personality disorder, which is very commonly accompanied by a coping mechanism of, at the very least, ideation, if not conditional behavior of suicidal thinking as a coping mechanism. So, various other disorders are included here, but borderline is the predominant disorder. And the data, which I didn't show you from the Netherlands, shows, again, the same. Almost half of the patients have personality disorders, and half of those have borderline disorder. Now, I showed you, tired of living and completed life in Netherlands. And here, two polls, both, so it was a reproducible finding, polling the Belgian citizens. They decided that after, they endorsed, 40% of them, endorsed that after age 85, that expensive medical treatment should not be provided. So no matter that the sole criteria be that you're 85 years old. So again, in a culture that has allowed a death option, this is how it evolves. That now 4 out of every 10 Belgians say, if you're 85, we probably shouldn't give you any kind of expensive medical care. Should just give you something palliative. Okay, now let's cross back into Canada, where since 2016, it's the largest country in the world that has been doing the most cases. Many people have called this a euthanasia frenzy that's going on there. So basically in 2016, this law, C-14 law, was developed by Parliament after a series of cases where they, first of all, the law legalized euthanasia as well as assisted suicide, but it's almost trivial because, again, when you have both, people choose euthanasia. They came up with a unique Canadian term, which is death in the reasonably foreseeable future, not statutorily defined. In nowhere in the literature is it defined the reasonably foreseeable future. So it's not like 6 months, 12 months. So it was very vague, left open, but it was generally felt to be tethered to the idea of end-of-life terminal conditions. They followed the Benelux model and said that intolerable to the patient and considered untreatable would be criteria. There would be no requirement to inform the family. And unlike what I told you in Belgium in 2019, patients can refuse evidence-based treatments for anything. However, mental illness was not explicitly excluded in this, but generally it was understood that because it's very difficult to prove that a mental disorder is untreatable, psychiatric patients were felt to be implicitly excluded from that. So here's the uptake in Canada. Remember the 500% increase in 20 years and the 1,000% increase in 20 years in Belgium. Well, in just 7 years, there's been a 16,000% increase in Canada. The 16,000 that you see there is the numbers aren't out yet in 2023 for 2023, but it's probably, from all indications, going to be more than 16,000. 4% of all Canadians who die by euthanasia. In Quebec, there's a particular enthusiasm for this. In 2022, 7 out of every 100 people who died in Quebec died by lethal injection from a doctor. Now, in 2020, the bill was amended, and they decided, again, through some court cases, Parliament was reassessed, and Parliament decided that the idea of death in the reasonably foreseeable future was too limiting, so they struck a new law and got rid of that, and went with just the Benelux model, intolerable and irremediable, and that opened people, just as in Europe, with chronic illnesses to possibly have this. Now, they established 2 tracks. One, the old track, which is if death is reasonably foreseeable, you have a 90-day waiting period between request. The 90-day waiting period is waived. If your death is reasonably foreseeable, you can have your euthanasia the same day you go in and ask for it. If your death is not reasonably foreseeable, if you have a chronic illness or a disability, but it's considered intolerable to you and irremediable, you do have to wait 90 days between your request and the delivery of the lethal concoction. Still, no requirement for evidence-based treatment. And they said that although mental illness is not considered to be an illness, disease, or disability, they were all ready to pass this excluding the mentally ill more explicitly than the first law, until a last-minute surprise. On the day of the vote, an amendment was introduced at the last minute by a member of Parliament who is a psychiatrist, who said, I propose that we remove the exclusion of psychiatric disorders in 2 years, and pushed it through, and it was voted on, and it passed March 11th, 2021. So now people with chronic illnesses, non-terminal illnesses who meet these criteria are eligible for euthanasia in Canada, but the mentally ill, that would come up again in 2 years in 2023. Well, there were all sorts of backlash of this. A special advisory group said, look, there's no evidence anywhere in the world's literature to support being able to identify irremediability in any individual case of mental illness. And there was a lot of discussion. And so in March 2022, the can was kicked down the field, and they said, okay, wait, we'll postpone it to March 2024, which is basically last month. Meanwhile, there were other pushbacks. There was an attempt to pass a law explicitly excluding psychiatric disorders from these procedures, to say at no time will that be allowed, and that law was defeated last October. Then the medical schools, the academic departments around the country of psychiatry became increasingly disturbed by the prospect that there was a deadline looming that would open the door to their patients. So the chairs of all 17 academic departments of psychiatry wrote a letter to Parliament saying, basically, we're not comfortable with this, and we're not ready to distinguish those from whom suicide should be provided from those from whom it should be prevented. And so I'm going to skip that. And meanwhile, the Canadians, were getting increasingly enthusiastic about this. This poll of 1,000 Canadians said, we think euthanasia would be okay if a person simply could have treatment, but they're unable to access it because they live in a rural community or they're too poor, that it's okay. Half people say it's okay if you have a disability. 30% said being homeless should be okay. We should allow homeless people to have euthanasia. And impoverishment did not constitute any kind of a coercive condition, almost 1 out of 3 Canadians. So there was a lot of expanding enthusiasm. But because of the pushback from the chairs of the Department of Psychiatry, by the way, here's an interesting cartoon, the suicide prevention program and assisted suicide, and look at which side has the steps and which side has the ramp. So basically, in March of this year, they delayed it again. So psychiatric patients will not be eligible for another 3 years, postponed to a time certain, March 3 years from now. So we'll still study it, we'll get back to you, but it's been kicked down the road another 3 years there. I had mentioned transplants in the Netherlands, it happens in Belgium as well. So it turns out 6% of every transplant in Canada is done after what they call MAID, after euthanasia. In fact, there's now a emerging effort in Canada to not do organ donation after MAID, but before MAID. In other words, put the patient to sleep under general anesthesia, harvest the organs while alive, because living organ donation is the best. Think of typical renal transplants. While the patient is still living, then after the donated organ is removed, crank up the anesthesia to kill them. All people who are working in the space of euthanasia are encouraged to discuss, even if the patient doesn't ask, to suggest that organ donation be a consideration. I'm going to skip that. Let's talk about the situation in the United States. Just a brief overview. So basically, we now have in the US, there are 12 jurisdictions that have legalized physician-assisted suicide, not euthanasia. Although psychiatric illness is not explicitly excluded, the criteria are that not insufferable or intolerable, but that you have 12 months, in most cases, sometimes 6, but that you're considered terminally ill. By the way, that it's unclear in the statutes, is that terminally ill even with treatment or terminally ill if you don't have treatment? A lot of the statutes don't specify that. In fact, by the way, this is the typical concoction for physician-assisted suicide. At the moment, there are 19 additional states that are pending legislation, and these 4 states who already have legalized physician-assisted suicide are pushing it further. The low-hanging fruit of the terminally ill, the very end-stage people, but these 4 states are pushing to expand the ability to do these procedures, write these prescriptions, to nurse practitioners, to lift the residency requirements, to change the waiting period from 2 weeks, which it typically is, to 48 hours or less. There's a whole controversy about conscientious objection and what to do with that. In these laws in the United States, first of all, they all have the following in common, except Hawaii. There's no mandatory mental health assessment. Hawaii, you have to have a mental health assessment, but it can be from any mental health professional, including a licensed counselor, a family therapist, a substance abuse counselor. It doesn't have to be a psychiatrist or a physician. There's no special training from those who do the evaluations, first opinion, second opinion, in any of these for training and capacity assessment, something that I consider actually a specialty in our field. Not all psychiatrists, myself included, are trained in a capacity assessment, because you have to have capacity for these procedures. No attempts at palliative care are required. No attempt at psychiatric treatment for people who want this suicidal option are required. Any physician can act as a second opinion, including your own partner in your own practice. Doesn't have to be independent. No witnesses are required to verify that there wasn't coercion at the time of people taking it. In fact, there's no statutory definition about what the definition of coercion is, where you have, where do you go from encouragement to being coercive. No minimum length of doctor-patient relationship is required. Doctor can meet you for the first time, and at that initial visit, approve at least the first opinion or the second opinion, approve your assisted suicide. And again, we've talked before, patients can refuse treatments like dialysis, et cetera, thus converting a treatable condition to a terminal condition so they can produce their own terminal state. And there's no tracking of the medications once they are dispensed. So here in California, just in the last year, from 2021 to 2022, there was a 63% increase. You can see in orange the number of, well, in blue, the number of prescriptions written, and in orange, the number of prescriptions taken. So 43% in 2022, which is the latest data I have, in California were unused. In Oregon, again, 25% of the scripts, we don't even know what happened to them. But it appears that there are about 1/3 of the medications that are dispensed go unused. As a matter of fact, we don't even know what happened to them. They're not required to be returned. They're stored in someone's closet. In one particular case, we actually learned that somebody stored this box of barbs for over 1,500 days until they used them. So we don't know anything about diversion. So in terms of referral for psychiatric evaluation, in Oregon, if in the opinion of the attending physician, the patient should consult a psychiatrist for either capacity or treatment, then they should refer, if in the opinion. So in the early years in Oregon in 1998, about 1 out of 3 patients were referred for psychiatric evaluation. As docs got more comfortable with all of this, that number dropped to basically 0 or less than 1% in recent years, are actually felt by the mostly non-psychiatrists who are approving and evaluating these patients for referral for either capacity assessment or treatment. And in 2022, Oregon lifted its state residency requirements. In fact, in 2023, 6% of all prescriptions were written by non-residents. Vermont last year lifted their residency requirements. So now, physician-assisted suicide is available to any citizen of the United States as long as they can travel, which may not be possible for some people who are terminally ill, but nevertheless, de facto, it may not be happening much yet, but de jure, any physician and any resident in the United States can now access by going to these states. In terms of, there's an interesting story. This internist at University of Nevada tried to transfer 2 patients to California and Oregon for treatment procedures not performed at the hospital. In 2 different insurance companies were involved, and in both those cases, the insurance company denied those transfer requests. And this doctor says in both cases, the medical director of the insurance company said, "We're not going to cover that procedure if you transfer them, but would you consider assisted suicide? We'll cover that." That's the emerging landscape. Now, what about psychiatric patients? Well, we have already gone into those waters and put a toe there. So a psychiatrist in this bombshell of a paper in 2022 published 3 cases of what she decided what she wanted to call terminal anorexia in Colorado. She provided all three with assisted suicide prescriptions. 2 of them used it. 1 of them died before she could use it. So she argued that because terminal illness was a criteria, that these people were terminally ill, terminal anorexia, and they met the criteria. And so we've now had 3 documented bona fide cases of psychiatric physician-assisted suicide. In fact, my colleague in Colorado tells me that for eating disorders patients who are going to commitment hearings because of these 3 cases, their defense attorneys are starting to argue that allowing them assisted suicide is a lesser restrictive alternative than involuntary hospitalization. All right, let's talk a little bit about the ethics. The way I see it, unethical ethics are better than no ethics at all. I'm not entirely sure I agree with that, but some believe that. You know, you have to think about this possibility. Or this paradigm, are medical ethics and societal ethics somewhat different with a lot of overlap? Or are they coincident? Or should medical ethics be the same as the ambient ethics of society? It's an important question. It's a question I won't answer right now because it's a very difficult and deep one. I particularly support the idea that they are not identical, that we have a venerable, over 2,000 year legacy and tradition of medical ethics, which has been under deep consideration, that we have an ethics that have survived societies that have come and gone. But if you'd like me to try to make the case for why I believe this to be true, I have 2 other talks that really dive into this. One is about the role of the leading psychiatrists in the Nazi Holocaust and their euthanasia program for the mentally ill. And another talk, if you'd like to invite me back, is the role of conscientious objection in healthcare. Both of those center around making the case that these 2 circles are not overlapping. But what do our professional societies say about this? Well, the American Medical Association has on 4 occasions, the latest November, just this past November, said that these procedures are fundamentally incompatible with the physician's role as healer. By the way, they also have said, as far as what should we call it, thoughts can corrupt language, language can corrupt thought. There's arguments to be made with all these euphemisms or physician-assisted suicide after a very deep dive with all sorts of stakeholders and testimonies and scholars and clinicians and patients. They decided we should retain the term physician-assisted suicide. The word suicide should be in the name of these lethal prescriptions because the Committee on Ethics and Judicial Affairs and the AMA decided that this is indeed a species of suicide. The World Medical Association, which has 181 member countries, including Belgium, Canada, the Netherlands, is firmly opposed to euthanasia and physician-suicide. They recently reaffirmed this, and as a result of this, Canada, the Netherlands, and Belgium have all dropped out of the World Medical Association. They no longer belong because of this. The American Psychiatric Association follows all the AMA ethics, so we basically agree with the AMA statement that I showed you, but we added an additional statement. I actually helped to craft this. We passed it unanimously in the APA Assembly in 2016 as a special message to, at that time, Belgium, Luxembourg, and what was brewing in Canada, that a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death, right? That includes patients in our wheelhouse, non-terminally ill people. So the fundamental ethical arguments support this, and I'd like to briefly touch on the first 2 and more deeply the last, are the concepts of autonomy or self-determination, very venerable principle, especially in contemporary medical ethics. The idea of parity, justice and fairness, and the question about whether psychiatric disorders are futile, can be futile, whether there's such a thing as untreatable conditions. Well, with regard to autonomy, there's no question that a principle of the sanctity of life, which has long been predominant in both Western and Eastern civilization for thousands of years, tends to often carry with it religious connotations, although I will tell you that a tradition older than Christianity, the Hippocratic tradition, actually very much embraced this. And as a result, it had its Hippocratic oath that said, I will give no man a poison nor instruct anybody else how to do so. So it's not strictly a religious idea, but it has been eclipsed more contemporarily with other important ethical principles: autonomy, fairness, and justice. However, autonomy, this is from the most widely read text of medical ethics, self-rule is that's free from both controlling interference by others and from inner limitations, right? However, I want to argue, and as in this paper, mental illness itself undermines that inner limitations, personal autonomy, the capacities of a person that enables them to live a meaningful life of their own making. So when it comes to psychiatric patients, we're on somewhat rather debatable grounds about how much autonomy is interrupted by mental disorders. And in fact, we're talking really not about true autonomy. This is pseudo-autonomy. Some have called it heteronomy, because it's still the doctor who decides, all right, I believe you that your condition is unbearable, but I don't believe you that your condition is unbearable. And I also basically get to make the majority claim as a physician about whether your condition is untreatable, but not your condition is untreatable. So at the end of the day, it's really still the doctor's decision. So it's not true autonomy in that sense. Now, with regard to the issue of parity, which we embrace very much in psychiatry, one of the problems is wherever you draw the line for eligibility for euthanasia, the people just on the other side of that line make an argument based on fairness and justice. Well, 12 months, why not 13 months? Physical suffering, why not mental suffering? Capacity, well, why not, surely those without capacity suffer, and we allow proxy decisions to be made for them by proxy appointees. Why not them? And so it goes. And so in every jurisdiction that has started this with a low-hanging fruit that is the terminally ill, inevitably, because of the arguments of justice and parity, it gets pushed and pushed. And before you know it, you're at completed life, tired of living, no medical care, over age 85, and so forth. Now, I especially wanted to address this idea of whether there is such a thing as futility in psychiatric treatment. And really, the argument of futility is undermined by these four different ideas. The first two are that we in psychiatry have unpredictable diagnoses and prognoses. In fact, the diagnostic reliability, inter-rater reliability, test-retest reliability of psychiatric diagnosis in this review paper is between 66 and 76%. Not very good. And remember that if we're going to conclude something about futility, right, that's a prognosis. And prognosis depends on diagnosis. A reliable prognosis depends on reliable diagnosis. So there's a lot of fluidity in our diagnostic construct. I mean, how many of you have seen patients who've had a whole train of diagnoses over the course of their treatment? They even change the diagnosis by an individual practitioner in the course of their treatment. So you got to know what you're dealing with before you can conclude what's going to happen with or without treatment, indeed, until you can conclude what treatment to select. So this paper, in fact, when it comes to particularly major depression, right, our bread and butter in psychiatry, this paper showed that diagnoses were so unreliable as to basically be almost useless in clinical practice. The kappa coefficient is 0.28 in this review article. Remember that perfect reliability is 1. So that's a very, very low number. The past president of the Canadian Psychiatric Association said an extensive review of the literature shows we can't predict irremediability when it comes to mental illness. There's a big difference between being able to predict the declining course of a well-known medical ailment with understood biology, even if not with 100% certainty, versus making unpredictable assessments about the course of mental illness. We already saw that expert advisory group and their conclusions up in Canada. Now, what about the treatment accessibility? The World Health Organization said the number one reason for inadequate recovery for mental disorders worldwide, including the US, is inadequate access to mental health services due to inadequate finances, not sufficient treatment facilities, not enough treaters, not enough subspecialty experts in whatever, eating disorders, schizoaffective disorder, and so forth. This paper brings out in JAMA Psychiatry that we have a tremendous crisis in the healthcare of anorexia nervosa. Remember, anorexia were those 3 psychiatric patients that were given assisted suicide drugs in Colorado. That we have a significant lack of specialty centers, lack of training, inconsistent standards for treatment. Frankly, I think eating disorders is a specialty, which is not mine. When I have a patient who comes to me with an eating disorder, I refer them to a specialty center. That we have a couple of them in Baltimore because there's a great deal of clinical experience there. In Canada, so these are average waiting times in the individual provinces. You can see in Nova Scotia up to 53 months to get a visit for any kind of health care. By the way, I remind you that for patients who have chronic illnesses, not death in the reasonably foreseeable future, they only have to wait 90 days between their request and being granted their euthanasia ticket. And for mental health care, the average waiting time to get in is 6 to 12 months. This in Ontario, there are 300 patients on a waiting list in a specialty eating disorder center. The average wait time to get your eating disorder treated in Ontario is 417 days. I just want to bring out this one case. So this patient goes to a hospital with suicidal thinking in Vancouver, and she's looking for psychiatric help. So clinician comes in and says, there are no beds in here. You really should be hospitalized, but there are no beds here, and there are no beds in a 50-mile radius available. And that there's an incredibly long wait, 6 to 12 months, to see any kind of mental health professional. And tells the patient, the healthcare system is broken, and followed by, have you considered MAID? See, that's what happens when you set this up as an option, right? Well, I'm sorry, we can't get you in. I'm sorry, we don't have enough treaters, have enough beds, but we do have MAID. Kind of like that insurance company in the US that said, we're not going to pay for you to transfer your patient to get, special neurosurgical care in Oregon, but we will pay for their MAID if you transfer them there. In the Canadian Journal of Psychiatry, this paper shows that only about half of those with depression receive minimally adequate counseling or minimally adequate psychotherapy, antidepressant therapy. So even when you get a patient in to treatment, the level of treatment, the state of the art of the treatment, tends not to be up to snuff. And then there are the financial issues. I mean, here in the US, we have, despite the parity law, it's more realized in the breach by most insurance companies than in the observance of the law. We have ghost networks that purport certain doctors are in the system and they're not. I mean, I've appeared in many insurance networks that I never even heard of list me as a provider. There's a very high rate of uninsurance, particularly among the mentally ill compared to those with other illnesses. And 51% of psychiatrists in the United States do not take insurance versus only 2% of other physicians. And our psych patients are more likely to be socially marginalized and in the economic underclass. You can see that our patients are more likely to be in the lowest 2 quintiles of income compared to the general population. So is that a coercive matrix that allows people to say, and we're seeing in Canada, I can't afford treatment. Nobody will build a ramp for my wheelchair. This is a real case I'd like made. I'd like euthanasia, and it was granted. And then finally, there's so much that we can provide. So many different treatment options that are out there, some of which are specific for certain conditions, others apply to many, and some of them are really hard to get. The ones in red here, ketamine, clozapine, dialectic behavior therapy, ECT, vagal nerve stimulation, transcranial magnetic stimulation, psilocybin, an emerging treatment. It's very difficult to get them. And as a matter of fact, I'm a little peripherally involved with the first case of that patient that I showed you, the psychiatric patient in Holland, to try and get her to come to the US to work with a colleague of mine who is doing ketamine-assisted psychotherapy and getting wonderful results in very treatment-resistant patients who have not had results elsewhere before. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. And even when you try a treatment, there's very inconsistent response to those treatments. So look, here's the issue. The issue is if you medicalize suicide and say there are a segment of people who can get their suicide provided by doctors, you are morally outsourcing it to the medical profession. And I want to suggest to you that a very important part of suicide prevention is not stigma, but something different. It's not stigma. We can discuss what I think the differences are, but taboo. That suicide, the taboo on suicide is an important part of public health efforts to minimize suicide. But when you say it's eligible for some patients as a medical procedure, you're messing with the taboo. Now, what's the consequence of that? It may well be suicide contagion, which is a thing, as you know. So in this decade, 2 decades, the United States had a 28% increase in suicides across the nation. But Oregon, in that same period of time, which has had legal physician-assisted suicide, has nearly a 50% increase between those years. So that's a very significant difference. How come Oregon pulled out way ahead of the national statistics? Is it suicide contagion? We don't know. But should it be studied? It absolutely should be. Should it have been studied before the law was made? It absolutely should have been. So I think that these procedures invert the fundamental ethos of who we are and what we do. What we do is we prevent suicide in psychiatry. We do not provide it. It's a very fundamental thing that I believe defines us. Our intent, yes, we want to ameliorate symptoms, but we also help people build coping mechanisms for demoralization and discouragement. We help to mobilize their support system. We help understand the context of suffering. We help people find a path to a better future. That's what we do. And in fact, we even have skill sets to help them make meaning of the suffering that we cannot resolve because of our skill set in deeply listening and the accompaniment of patients on the journey of suffering, offering our presence and hope. And I maintain we do this more skillfully and have more training in this than any other specialty in medicine. And I think that these skills are independent of any diagnosis. So it's not like, okay, we're only dealing with people who are depressed. We can do these things if you have depression or schizophrenia. I think we can provide this for any demoralized, suffering human being. And to put us in the position of offering assisted suicide is to invert that ethos. So this could be the treatment plan of the future. We can offer you psychotherapy, medication, all of these somatic treatments, residential treatments in the rare case when your insurance will pay for it if you can afford it. I'm depressed, doctor. Have you considered assisted suicide? Could also be on the treatment menu. So I am concerned that this may be the euthanasia, the death of psychiatric ethics as we know it. John Mayer again, just as the Pope should not perform abortions or the Dalai Lama shouldn't take up arms, psychiatrists should not counsel or abet suicide, for in doing so, we have misunderstood and betrayed our vocation and profession. Validation of suicide or assisted suicide by psychiatrists is therapeutic and professional hypocrisy. My own chairman that I trained under at Johns Hopkins wrote back in the Kevorkian days an essay where he said, patients are seduced by isolating them, sustaining their despair, revoking alternatives, stressing examples of others who choose to die, and sweetening the deadly poison by speaking of death with dignity. If even psychiatrists succumb to this complicity with death, what can be expected of the lay public? And one of the great ethicists, medical ethicists of the 20th century said, when psychiatrists, as in Holland, undertake to kill their patients with public support, intuition and revulsion have fallen asleep. Only argument with all its limitations can hope to reawaken them. And I hope that I have made some arguments today that have given you some sense as to why I think that this is neither good medical ethics nor good public policy. Thank you very much.
Thank you, Dr. Komrad. We'll take questions now. Do we have any in the audience? And if you're viewing online, if you'll enter into the chat section, we'll ask that for you. Or comment, doesn't have to be a question. Nothing?
Maybe I made too convincing of an argument.
You did such a great job. We do have one here.
Okay.
Dr. Komrad, thank you for this presentation. I think it was amazing. I do have one comment that just came to mind when you mentioned the psychiatrist there saying, have you thought about suicide? The equivalent, at least in my mind, would be a patient with cardiovascular disease coming to a cardiologist and then them saying, well, we have these treatments, but have you just thought about having a heart attack? I don't see the difference there, as far as our perspective goes, but again, appreciate the lecture.
Yeah, I mean, there may not be a difference. I mean, frankly, I hope that you've intuited that I have concerns about these procedures for everyone. I do not think that any of this belongs in the house of medicine. I had mentioned Hippocrates. In ancient Greece, there were the Asclepia, which were dedicated to the god Asclepius, the god of medicine, where the iatros, the physicians, practiced. There was one Asclepian that was run by Hippocrates. Now, it was commonplace because there weren't that many treatment options back in 325 BC for patients. So almost all of them practiced euthanasia as a potential option for all conditions. Hippocrates, however, said, if you come work for me or train with me, you have to do, first of all, one very important thing. You have to subscribe to certain values. You have to profess a set of values, hence the word profession. You have to take an oath. And historians have said the most singular line in that oath that at the contemporary time distinguished the Hippocratic Asclepian from all others was, as I said before, I will not give anyone a poison nor teach anybody else how to do so. So we don't do euthanasia in the Hippocratic Asclepion. That is the root from which the mighty tree of medicine has grown. Just like, if you will, by analogy, starting 300 years later, Jesus Christ was the root from which the mighty tree of Christianity and all of its values grew, right? So the house of medicine is built from the boards made of that tree. So again, if a society wants to legalize these procedures at its peril because of the slippery slopes that are not just theoretical but actually happening, as I've illustrated, then society, I think, needs to move it out of the house of medicine. You know, it's easy to teach a pharmacist, if they want to do that in their house, how to give a lethal injection, and set up a whole other profession of thanatologists to do this. But it should not be physicians. It shouldn't be in the house of medicine. In fact, probably it should be in the philosophy department or the political science department or the law school, which is where all the scholarly advocates of these things tend to hang out, because they don't have to be the one that's actually writing the prescriptions, pushing the needle, or were acculturated to the profession of medicine. But I want to say one thing about that, and then we'll take the next question. I'm sorry. Obviously, I have so much to share with you. In Canada now, people are saying that a litmus test for people applying to medical school should be, are they comfortable with MAID or not? Because if you're not comfortable with MAID, now we have MAID, now it's normalized, you probably shouldn't be a physician. And that's being proposed and argued vociferously in Canada now. I'm sorry, let's go on to the next question.
Okay, time for one more question.
Hi, thank you for this amazing lecture. This may not be the most eloquent question, but I was just thinking about how these concepts are being brought up more and more, especially in the psychiatric setting that we would normally see in more of a more like physical medical setting, and the introduction of like advanced care directives in a psychiatric post, and how that may kind of be towing the line towards getting us closer to physician-assisted suicide or euthanasia in psychiatric populations. I'm not super well versed in it, but I know there's a section where patients can say, these are the only medications I want to be treated with. And is that kind of opening a doorway that could then, you know, progress further?
Right, so once you open it, right, then there are many paths to get there. Once you've said, okay, psychiatric patients are eligible, any patient is eligible. Patients can refuse, they can do advanced directives and so forth. I was telling Dr. Prasad about a case before we began. So they have advanced directives in Belgium. And there's a large number of people with dementia who have advanced directives, because that's allowed. So there's a whole other lecture about dementia and euthanasia to give. So this one patient who had an advanced directive for euthanasia, she developed dementia. By whatever criteria, and I can't tell you what, the doctors and the family decided she had reached the point where it's time to execute, pun intended, her advanced directive. So they came to her with the needle to insert the IV, and she screamed, and she struggled, and she fought, and they had to put, they tried to put a sedative into her coffee, and that didn't work. So ultimately, the family had to hold down all four limbs as she struggled, as they started the IV and pushed the lethal medicines. So those are the kind of scenes that you can get into when you have advanced directives, because you brought up, you know, impending advanced directives. So far, you know, Georgia is not one of the states that has it, but there are strong lobbyists, particularly an organization called Compassion and Choices, that is the vanguard and very well-organized, well-funded movement. And they go around the country trying to get these laws started. And their method is to go to the local medical societies and get them to part with the AMA and go neutral. That's their, just go neutral. Just say we're neutral on the issue. And if you're neutral, then they can take that to the legislature and say, this is the way it always happens in all these states that I showed you. Then they can go to the legislature and say, look, even our state medical society is neutral about it. And that's the way you can push this agenda. If you can stick around, I think we agreed that, especially for those who can stay, we can keep the discussion going. So are there some other points, some other questions?
I think that's it for the recording. So thank you, Dr. Komrad, very much for an excellent presentation.
And by the way, for the recording people, before you go, I have my email address there. I maintain a curated mailing list of colleagues, if you're interested, where I occasionally send out developments, news stories, sometimes an appropriate peer-reviewed article about this topic with particular attention to psychiatric patients. So if you'd like to be on my mailing list, there it is, mkomrad, first initial, last name, @me.com. So feel free to email me and I'll add you to the list.